Hi, fam! Welcome to you as we enter into a special Memorial Day themed episode about combating stigma and improving mental health support for our military personnel and vets with OCD, with special guest expert and advocate Dr. Elizabeth McIngvale. So settle in because there's some important and heavy conversation ahead. I'm Nicole Morris, licensed marriage and family therapist and mental health correspondent. And let me be the first to say, welcome to the family, the OCD family, that is. I am here to create a community of support for family members, spouses, partners, parents, adult children, as there may be adult words, and chosen family of OCD sufferers and their community. I've had over 22 years of experience in the mental health field, but please note that this information does not qualify or substitute as a diagnostic evaluation, therapy, or treatment, and it is presented on an as-is basis. Please follow up with a qualified mental health provider in your area regarding concerns for yourself or loved ones. Thank you for joining us today. Now, let's get started. All right, fam. Welcome back. Welcome to the end of May. Today is pretty special because A, it's my kiddo's last day of school, summer break is upon us, which means B, this episode wraps up my season 2 finale of long form content because next week we launch into the return of my summer series, The Water Cooler Chats. So for newer fam, if you've joined us sometime throughout season 2, the Water Cooler Chats are short form content, think 5 to 10 minutes max, still available wherever you enjoy your podcasts and YouTube. And while Water Cooler Chats give us some concise quenchers to help us learn and cheer on our loved ones with OCD, it also allows me the room to spend more quality time with my kiddos while they're on summer break. But admittedly, my oldest son loves my summer series the most because if you tune into the video broadcast on YouTube, I animate the episodes with Legos, and my son is my chief building foreman. In fact, all season long, he's been suggesting different themes and directorial interpretations that I can create. And I do love that he feels so empowered to storytell and be a part of the process for the Water Cooler Chats. But that means my long-form content with amazing guest interviews is reaching its finale today, though we will return with the start of Season 3 at the end of August. And we are so fortunate to have such a prestigious trailblazer, guest expert, and inaugural International OCD Foundation advocate, Dr. Elizabeth McIngvale, Ph.D., here with us. So many thanks to Liz for carving some time out of her busy schedule. And if you've ever caught the Lunch and Learn live streams or many of the community chats over on IOCDF's YouTube channel, along with former podcast guest and friend Chris Tronson, then you're likely familiar in part with Liz and her dynamic work. But whether you're new to her or not, let me just take a second to brag on our esteemed guest. Liz is the director of the OCD Institute of Texas, where she maintains an active clinical and leadership role, in addition to serving as faculty at Baylor College of Medicine in the Department of Psychiatry, where she is involved in research. Her clinical interests focus on OCD, anxiety disorders, mental health stigma, and access to mental health care. She was the founder of the Peace of Mind Foundation, a nonprofit foundation dedicated to OCD that has since been acquired into the International OCD Foundation. In 2020, Liz was active in OCD Challenge, a free self-help website, which you can imagine was very timely and a super important resource, especially as COVID was obliterating resources and treatment access across the board. As mentioned earlier, Liz was the first ever national spokesperson for the IOCD app, where she now serves on their board of directors. Liz has received numerous awards for her advocacy and impact on the mental health field and currently serves on various mental health and nonprofit boards. She is internationally known and recognized for her clinical work and advancements around the stigma in the OCD field, and so it is quite an honor to have her joining our OCD family community for today's important conversation. So if you're here in the US, and if you are catching us hot off the press from when this episode goes live, we are entering into Memorial Day weekend, which is a sobering yet important weekend where we honor the men, women, and all people who have paid the ultimate sacrifice, whether as active duty military or veterans. It's such an important topic, and because we're honoring those we've lost, then you can probably guess that we will be talking some about death today. But just to extend that trigger warning and provide the fam here with informed consent, we're also going to be addressing death of military and vets from suicide or unaliving oneself. So please proceed with discretion and remember this podcast does not qualify or substitute as treatment. So if you have a concern about yourself or your loved one, please reach out to a provider in your area. Or in the case of an emergency, dial 911 or your country's emergency code for immediate help. Additionally, a quick housekeeping note for any new fam. All the resources that we discussed today will be available over at this episode's blog at ocdfamilypodcast.com. So if you want to learn more about Liz, research that we discuss, you name it, I will have all the details over for you on the blog. But for now, let's go ahead and dive into today's conversation because, woof, there is a lot of ground to cover. Well, welcome back to the OCD Family Podcast. So I'm so excited to have Dr. Elizabeth McIngvale with us today. And she is a powerhouse in our field. She has done so much through the International OCD Foundation, as well as just in her own clinical practice and within her own community reach. And so welcome to the OCD Family Podcast, Liz. We're so excited to have you today.
Thank you so much. I'm really excited to be here and looking forward to the conversation.
Yes. So, first off, we have such an important topic today, but I wanted to ask you because it's just been really interesting to hear and learn about all our amazing colleagues and researchers in this field and what has brought them into treating OCD in the first place. And so, would love if you're willing to share with the fam here what brought you into the OCD sphere in terms of treatment.
Yeah, good question. So my own personal journey, really. I mean, it was a journey after my own personal journey to get into this field and into treating. But I was diagnosed with OCD at a young age and underwent intensive treatment. I was inpatient at the McIngvale clinic 2 different times and really spent many years, decades of my life trying to figure out how do I actually manage this illness? What does that look like? And how do I get to a place of freedom, which is what I talk a lot about. And so I was dealing with my own journey. And as I think two things really stood out to me. The first was the discrepancy between people who have OCD and people who could access appropriate, effective, evidence-based treatment. And that really bothered me. And so I really wanted to make a difference and make a commitment to allowing people to have that option and to figuring out how I could do that for the rest of my life, right? How I could continue to fight that and push for that. And then the second piece was really being able to send this message of hope and destigmatize OCD. I really wanted to also, after struggling, be able to help people see and understand that they're not alone and that there are other people dealing with OCD, but that there's help and hope available for you. I think so many times when I was first diagnosed, first of all, no one talked about OCD. There wasn't advocacy. There wasn't podcast. Like this didn't exist.
Yeah.
And so I had this big interest in doing that. But I also think at the same time, many times people are sharing their stories and they're incredible and impactful, but we don't always leave those messages of hope and make sure people understand that, yes, you can struggle and there's help available. And so I wanted to be a part of that. And so I started doing advocacy really quickly after treatment and really fell into advocacy with the International OCD Foundation. I was the first ever national spokesperson and did a lot of talks around my own personal story. And as I did that, I really clearly understood and knew that I wanted to make a career out of this and that I really wanted to be a clinician and be able to help others in addition to doing advocacy. And so I then made that my education route. And of course, did the formal education, formal training that I needed before I could enter the field as a clinician as well as an advocate. But that was my journey and that's where I'm at. And there's been a lot of new things I want to learn and understand and continue to grow from a career perspective, but it all lines up to access to effective treatment.
Yes, very, very well said. And I think that it's not only impressive to hear, because I think especially whether you've gone through one residential or inpatient treatment, we go, oh gosh, this feels so intense. What is life going to hold for me? And you're living proof. You're a living example of actually the world's your oyster. There could be a lot of different things, but I love that emphasis on hope and access to appropriate care. And so thank you for sharing that bit about your story. I also am a lived experience person, but I, on the flip side, did not find out until I was already treating OCD. And so it's always interesting to hear how people came into this field. And today we're going to be we're going to be talking about active duty military, veterans, and I know we have international fam, but we're going to, for the most part, be talking about the system of care and how military functions here in the US. But I want international fam to hang because I think it's still worth having a discussion and just doing some critical thinking about ways that we can have more access, have more hope, just really in line with that message that you were talking about, just even more broadly for OCD. And so, what brought you into the realm of working with active duty or veterans? Would love to hear more about your affiliation there.
Yeah, so obviously that's not necessarily the entire population I work with now, but I did do my postdoc at the VA here in Houston and really was able to work hands on with veterans for a year during that time. And I think that for me, so many things really came about that. I think the first is obviously my gratitude and appreciation for the veterans in the United States and for those who serve our country. And number two, being able to help veterans understand that treatment is available. I think the biggest thing that really draws me into working with veterans is the stigma in the veteran population, I think is even stronger than in the general population when it comes to mental health and accessing treatment and receiving a diagnosis and all of the above. And so, yeah, just lots of work I think that we clearly know needs to be done, but also knowing that this is a population that is really struggling both with PTSD, OCD, lots of other mental health conditions, and one that is often in hiding much more than some of our other populations for various reasons.
Yeah, and even along with that substance use disorder, it's interesting because the very first episode of season 2 I had with Dr. Patrick McGrath, we were talking about that overlap of substance use disorder and that impact, even particularly within our veteran population. And so I love that we can round out this season to really be talking about and honoring people that are already putting themselves in a place, continuing to fight for their freedoms. For me to even have a podcast to be able to talk about this, and yet, mental health and even more broadly, medical health can become such a complicating factor when considering even enlisting in different branches of the military. And particularly, problems don't just stop there with active duty, but can follow into the veteran stages of their career. And so, one of the first things that we were going to talk about today is some of the different systemic support system struggles that occur. And we're going to kind of think about this from active duty and beyond. And so I recognize that your work is more with the veteran population, but I'm sure some of these systemic problems, and we can trace it back, started with or even before active duty. And so,
100%.
can we start with just kind of discussing, first of all, there are safeguards in place, and OCD, amongst many different mental health disorders and medical conditions, can disqualify you from enlisting in the first place for service. And that can feel harsh sometimes to people because they go, well, everybody has mental health. And so you're saying, I don't have a right to defend and be a part of this system if I have mental health struggles. And that's not how I think is most helpful to conceptualize this. And so, first of all, can we just talk about the safeguards and why it's important in the first place that we even have some parameters and boundaries when we consider mental health and active duty service?
Yeah, I wish I could answer all of those because obviously I don't make the safeguards. So I can't speak to the why behind all of them. But what I can say from a mental health perspective is that we want mental health conditions to be treated before we engage in really any activity if we
Right.
want a chance of being successful. But when you think about active duty population, you are going to be in vulnerable places. You are putting yourself in the most vulnerable situations and you are being forced with high stress, high trauma at times, right? High anxiety situations that what we would say from a mental health perspective is like your vulnerabilities and your triggers are probably going to be as high as they possibly could if you are actively serving in the military. And so, what we know from a mental health perspective is that if you have an underlying mental health condition, high stress situations will make that condition worse. They will increase symptoms. And unless that mental health condition has been appropriately treated, you are at a really strong chance of either a relapse or, active symptoms that become debilitating and disabling when you are put in these high stress situations. When you think about mental health in general, and we talked specifically about anxiety or OCD, when do you see it onset? You see it onset during puberty, during life changes and postpartum, getting married, getting divorced, losing a job, getting a job, going away to college. These big life transitions, right? Puberty hormones are changing, right? Because why? Well, you're more vulnerable, right? You are born biologically with these mental health conditions and they onset or exasperate at certain times in your life, right?
Right.
And those times are during the most vulnerable times. And so I actually wouldn't recommend that anybody with an untreated mental health condition purposely put themselves in these high stress possibly acute situations that are going to be putting them in like the most vulnerable states they could be in if they haven't had appropriate treatment.
Yeah, it's such a great point. And if you consider, fam, I'll look up the specific study that I'm thinking of because I'm not able to name it at this moment, but I will put it over on this episode's blog along with any other citations, resources that we talk about today, and more info on how you can find out more about Liz and the work that she's doing over at OCDFamilyPodcast.com. But if we look at the prevalence of, say, even college age, like having that transition into college, graduating high school, maybe leaving your parent or your caregiver's home, a lot of times, especially if we're already dealing with some severe manifestations of OCD, then we're really reliant on that environment to help provide and participate in those compulsions, that feeling of safety that feels necessary for somebody, whether it has to do with contamination, fears, harm, etc. Name a thing, it could be inserted there. And so you consider at that age where people may be emerging into college is usually going to be right after high school. Well, when do a lot of people consider a military career? Maybe they did some kind of training. What is it? What is it in high school?
It's ROTC. Is
ROTC,
that
that's
right?
what it is. Thank you.
Yeah, that's what I remember. That's what I
Yes,
remember it being, but it's
yes.
been a long time since I've been in high school. So
It has been a long time. So I was like pulling, I was like, I feel like R is in it. Yes,
yes.
thank you, ROTC. But a lot of people are going to enlist and then go to basic training or go to a camp. And whether we're going into combat or not, that's probably going to mean a move. It's going to mean a huge change in environment. It's going to mean a huge transition. And this is a big age where a lot of people may enlist. It's not the only age. People can always come later on in life, but this is going to be a critical time period of where a lot of people are going to explore starting their military career. And so we could see how going into a system, if you already have pre-existing mental health and you may not be aware it's OCD, a lot of people aren't. That's part of the stigma that we had to continue to keep educating folks about, right? And so going into that setting already with so many different changes, yes, could be a stressor. And so I think it is really important that we consider how the environment, combat or not, is already going to have such, in some situations, isolation. Say you're deployed and it's a non combat zone, you're still isolated, you're away from different access to resources, etc. But also, there's just so many different situations that can come up where you might feel like I'm already in this fight, flight, or freeze mode during basic training, during the learning the new protocols. It can be experienced as pretty rigid sometimes for folks. And so if you already have a mental health condition that says that these are the things I need right here to help me feel better, feel safe, to feel any sense of calm, and then you go into an environment that is living in fight, flight, or freeze mode because you have to be ready to act and react at any time in terms of safety. That's a very hard environment for any mental health disorder, let alone OCD.
100%. And again, you're talking about environments that, yeah, let alone forget if there's an underlying mental health condition. It is so stressful to begin with because of, yeah, like you said, multiple things, right? You're leaving your comfort zone, you're leaving a safe place, you're leaving your support system as you know it, and you're entering into not just huge life transition, but a huge life transition in the military, right? One
Right.
that is going to be higher stress, more rigid, different schedule, all of the above. So yeah, I think from many angles, we can all say pretty strongly that vulnerabilities would be significantly increased if you're entering the military.
Yeah. And there's also cultural pieces, whether we come from a different family culture or ethnicity where maybe mental health isn't something we do. Maybe we handle feelings or the problems that come up within a family, within our community. I can say here in the Midwest, within religious culture, sometimes that can be a barrier as well, because it can be a matter of, are you really experiencing a mental health difficulty, or is this a result of some sin or some conflict in your life that you need to resolve otherwise? And so we can see how different cultural barriers can also contribute to this. Military bases are sometimes in prominent areas, but a lot of times they're out. Like, I moved here from California, so a lot of times you're going to have like a little more. You're going to have different bases that are outside of the beaten path so that they have the room to do their training, etc. And so even when we think about, let's say there is access to mental health care, base or beyond, we might be in a really remote area where accessing even mental health is going to be a little bit more tricky. And so, considerations to keep in mind. But also, if you have a passion to be able to serve and you have something that disqualifies you from the get go from service, a lot of people feel the need to hide or not report something that could keep them. If their lifelong dream is to be a soldier, if their lifelong dream is to be a sailor or to be in any of these different given branches, this can be a really big problem.
For sure. And I think that there's also a significant chance that a lot of people in the military with anxiety or OCD or veterans with anxiety or OCD didn't know they had anxiety or OCD when they entered.
Right.
So I think that's also a big piece to take in is that you may not be hiding it. Because I think that if you have significant OCD, it'd be pretty hard to hide it going in. And it wouldn't be something I'd recommend, of course, because that just feels like a really difficult situation
Yeah.
and one that's going to set you up to be in a pretty tough spot. And a lot of people don't know what they have and what's going on until they're already in the military, right? Or it increases or later on it onsets.
Right. And so then you see, like we talked about before, how the pressure of that environment and how that can just exacerbate the issue there. And it can become a huge safety concern for everyone in your unit, but for everyone in your branch that maybe you're deployed with or in the combat zone with too, because there's already a huge pressure with mission readiness and being able to be reliable and safe with your peers. And so if you imagine too, somebody is already feeling the stress, then we have that amplified mental health experience once we're in a more remote place or we're in a combat zone. It would not only be hard to get access to care, but it can bring up some of those safety concerns in terms of if I need this person to have my back and we're going into a combat zone and they're in freeze mode and they shut down, then that becomes a safety concern because we need to be able to rely on each other to react and to complete whatever our mission here is. And so you can just see the complicating factors. And so those are some of the support system struggles that are already in place. But I also want to talk about, because you were talking about even more broadly in terms of OCD, some of the stigma that is out there around mental health. And I think too, because our armed forces and our military are such strong men and women and all sorts of different folks already volunteering, there's almost this stigma like you should be strong and having mental health isn't strong. Even though we know that's not true. We all have mental health too. But can we talk a little bit about some of the stigma that can be experienced, whether it's from the feedback and what you've learned in your time with the veteran population or just even stigma of OCD if we were in the general population? I think some of these things reign true as well.
Yeah, I mean, we know that stigma with mental health is significant. I think that it is more significant and prevalent with men to begin with. And so I think, especially when you think about military population and gender differentials, we know that there may already be an increased chance of stigma and the way it impacts individuals in the military or veterans. Add on to that, this sort of stereotype in the active duty and veteran population that I can't have something wrong, that I shouldn't carry this label, that I need to be strong and independent and fully capable of handling things on my own. And there's a lot of stigma and fear
Yeah.
that a diagnosis means you're going to take things away from me, that a diagnosis means I won't be able to do what I should be doing or have the same rights in my household that I want to be able to have, or people will look at me different. Sometimes people ask things like, oh, if I get diagnosed, like, can you not note that so other people don't know? And there's this misunderstanding that like there's HIPAA laws, there's safeguards in place. We can't go like share someone's diagnosis with the general population or with their next job that they want to get. A lot of people in the military go to high clearance jobs afterwards when they move back into civilian world. It is a transition and a shift for them as well. And they have a lot of anxiety about if a label is going to carry over, what impact that would have, but also what will my brothers and sisters in the military think, right? What will my boss think, my supervisor, and how will they handle that? And what might their own stigma be, or what are the ways they've heard mental health talked about prior in their own groups?
Yeah, it's a great point. And you think about if I say I'm having anxiety, or if you lost a buddy in combat and you're struggling with that, which is so human. Oh my word. It's totally understandable. Sometimes that fear of, well, if I say I'm having problems with this and I'm having nightmares about this potentially happening to me at night or any given symptom presentation, I'm hesitant to give too many examples because I don't want anybody to hear them specifically and go, well, she didn't name my thing. So that must not include me. No, it can vary in so many different ways. But yeah, I think there is that stigma of what will people think about me? And to be fair to that point, not every unit, and specifically, you can think of this just kind of in small group or organizational dynamics anyway. Some people aren't going to be very supportive of that. Like some people are going to be, for lack of a better word, dicks about it. They're going to be like, you have this problem, shut up. There's going to feel like there's more punitive consequences in reporting. And then other groups, they're going to be like super supportive and they may even help you access that care and say, I think this is really important. And not all things are created equal. So just having some anxiety versus I'm having nightmares and I can barely concentrate may be reported a little differently. But from my understanding, and if you have a different understanding, I would love to hear your expanded thoughts on this. But you're really only psychologically evaluated when you're first enlisting. And unless there's a problem where maybe a superior officer is going, I think we need to have another evaluation, you're not really actively being evaluated unless you are making that specific trip over to behavioral health or having a sick call and saying, there's anxiety and I think maybe I need an evaluation. So outside of those circumstances, there really aren't calls for psychological evaluation. And we have to consider having people in these positions, there's so much psychological stress that goes into putting your life on the line, putting your neck on the line, and fighting in these different branches. And so, would love to hear your thoughts on that aspect of things.
Yeah, I'll give a quick story, but I've got a great friend, Shannon Shy, who is a veteran and an incredible advocate. I don't have you had Shannon on yet,
I have
Nicole?
not. I would love to.
Oh, you'll have to have Shannon on. He would love to come on. And he was the president of the IOCDF and is a veteran and got his OCD diagnosis, received his OCD diagnosis while active in the military. And, Shannon's story is that, right? He started to display symptoms. He was really struggling. He was looking for help on his own in bookstores and self help. And he did, I think, seek out a supervisor to say, I'm struggling and I need support and help. And was able to get to active treatment while he was in the military. And it's an incredible story, but his recovery is incredible in the work that he does now to work with veterans and with others. But I don't know the ins and outs of what would happen. But I think about it kind of like, even if you think about just like an employer, right? Like your employer, when you first start on, they're interviewing you to see if you're fit for the job and if it makes sense and if you're qualified. And then after that, they're just assuming you can do the job, right? You're getting up, you're showing up to work, you're doing your job. And unless you go to your employer and say, hey, I'm struggling, or I need to take FMLA, or I need to seek help, or can you point me to human resources and help guide me? I don't know that they're going to be doing any continued assessments or right, unless you are performing, right? Or
Right.
there's a reason for them to say, hey, what's going on? And so I would assume it would be pretty similar.
Yeah. Yeah. Well, and so I've had the privilege of speaking with different people, both veterans as well as active duty and veteran military families. And because of just the complicating factors, and again, I think it speaks to not only the stigma, but the feared consequence and the desire to, with the utmost respect, approach these conversations. They wanted to remain anonymous. But one of the people that I was speaking with was even talking about how for their spouse, they were even assigned to a position within their military unit where they were in a hospital setting. And it wasn't supposed to be, quote unquote, a traumatic setting. But then also had a dear friend come in through that hospital setting. That dear friend ended up having an emergency situation that did lead to a loss of life. This is extremely traumatic. This was not what you're expecting and going into your day. This started to have a very dramatic effect on the person, which is absolutely understandable. And it ended up carrying to a point where there really had to be advocacy and really a conference around what's going on with this person and are they going to be able to continue to serve, and really having to be able to step in and advocate and go, yes, but this is trauma. Even in a non-combat assignment, even in something that we didn't expect, we'd end up having this traumatic event. This is huge. And just to see the difference in how different units were responding to that. Some units, they might go, yeah, that makes complete sense. We'll do what we can to support you. In other units, we might have to fight for it at a tribunal or other kind of panel to see if this person can continue to serve. And that, I think, just the difference of how things get handled makes for a lot of problems, whether we're talking about employers or the military, because not every group is going to handle things consistently. And that's probably one of the big pieces that's worth discussing here of how can we even promote more consistency, whether it's regulation or code, in terms of how we handle more transparency on how we problem solve different mental health or even new medical health issues as they show up so that we can decrease some of that fear. Because some of the stigma is based in, yeah, because that shit happened to somebody that I love and care about. And some of it is just the, I've heard stories and it may be completely debunkable, but if we don't have a conversation about it, we can't get down to the bottom of it or even create some advocacy for more consistent policy across the board.
100%. Yeah, no, I wish and would love if somebody could create the myths and facts, just simple little sheet that's just kind of like, is this true? Is this not true? What does this mean? What does this not mean? Right? All that sort of thing.
Yeah, yeah. And then again, when you're looking at different branches of the military, say the Navy versus the Army, like all of these different units too are going to have their own specifications in different ways that they function as well. And so there's some difference in what qualifies someone in this setting versus in the Navy setting versus in the Army setting. And so it does get very, very tricky and complex. Well, since we're the OCD Family Podcast here, we always like to think too about our family members, the dynamics that happen for military spouses or partners, for children and loved ones around our active duty and veteran population. And so I would love to think about even in, say, active duty situations, maybe you're living on or around the base. Maybe your loved one that's enlisted is dealing with mental health, but maybe it's you and you're afraid of the stigma that you could bring to your loved one. You don't want to be problematic for your family member. And you're trying to think of even how can I support them and not bring a negative stigma to our family, to our name, but also access the support that I need.
Oh, it's a good question. I think that the first thing when we think about stigma and how we debunk it is, I think before we go into like personal examples of what it's going to be like and how do you deal with this on the base, I think that as a society, we need to think about how we're just talking about OCD and mental health. And how do we make sure people have, like I said early on in this podcast, a good understanding that you can have a diagnosis, but that effective treatment exists and you can live a fully functioning life, right? Because we can't expect somebody to be willing to live on a military base and talk about their diagnosis of OCD if the general population doesn't understand that that can be treated, that you can live a full functioning life and that it isn't this mark on your name, so to say. Like, I think a lot of times we want the second piece to come first that, oh, you should be able to just talk about it and you need to be willing to do that. And it's like, yeah, but like, who am I going to talk about it with? Who's going to understand? Who's going to help guide me to right treatment? And so the first thing I'd ask is, do active bases have mental health resources that are good? And if I speak out about it, do I feel like I'm going to be pointed in a direction that's going to lead me to help and recovery? Or am I afraid to speak out about it because I know it's a never ending loop of not getting better and just now people knowing I'm sick, right? People are going to be way less scared or anxious to talk about their diagnosis if they feel like there's treatment, right? I think most people aren't that anxious to talk about breaking their foot if they break it, because when they tell someone or they talk about it, there's a path to treatment that's pretty clear. Most people know what that is or can give them that referral, or they would say, oh, go to this clinic. Here's where it is. This is the doctor who's great that I recommend, whatever. But the same thing doesn't happen for mental health and certainly not for OCD. And so I think the first step I always say is just education, is educating the military, educating the bases, educating family members that here's signs and symptoms and here's effective treatment. And like those things go hand in hand on that education. And I think that if that happens first, people are going to be more willing to talk about their diagnosis and then get themselves to appropriate treatment.
Yeah, and we often will talk about this in terms of people with lived experience or parents that are trying to kind of keep their kids afloat and are also like sinking in all of this. we talk about the analogy of if you're on a plane, put your oxygen mask on, and you're supposed to secure that for yourself first because you can't be of help to this other person next to you if you're not also taking care of yourself. And so I appreciate you talking about the education piece, and I pair that too with that self-care of even if you're feeling like I'm worried this could bring embarrassment or shame, if you're not taking care of you and you're wanting no matter what to support this person next to you, the best way you can support this person next to you is to take care of you. And so it's both that education and that you also have needs and you're a person. And if we're not addressing your needs, you're not going to be able to be charged and ready to support your loved one next to you. And so it really does become just as important as them treating and dealing with their mental health for you to also honor and deal with the things that are coming up for you as well.
100%. 100%. Yeah. I will say, and you know this because of your podcast and the title, is that oftentimes the family members are engaging in or doing treatment just as much as the loved ones. So you have an individual suffering, and then the support system has to be just as involved or committed to treatment as an individual because OCD isn't isolated to one person, right? The way it impacts family systems or reassurance seeking or these different ways it shows up, those folks have to not just be taking care of themselves, but they also have to be willing to do treatment. And so there's a big piece there that, yeah, it involves the whole system.
Yeah, and so then if we think about that as a systemic issue in terms of the education and the resources available base wide or program wide across the different branches of the military, it's a little bit of a parallel process. It's not just how can we treat then the person that's suffering with the thing, it's this family community process of we all need to learn about this and understand what it is and what it isn't, and so sometimes breaking into that sphere of advocacy within different institutions can be a big struggle. But I think that's such an important point that we don't just single out the person suffering with different mental health. We look at, no, this is a system wide problem. It's for the person to learn, but it's also for the system to learn, whether we're looking at family system or this branch of the military or this veteran population. It's the same across the board.
And the clinicians too,
Yeah,
right? It goes all the way through. And I will
yeah.
say that there has been incredible work done. When I was at the VA, we had a specific OCD task force and we were working to get the Y box, for example, actively integrated into the measurement system and the EMR that they use within, veteran populations so that it's much easier to be able to use a good, effective, valid OCD measure to assess for OCD. And so I think that there's so many changes that have to happen. What I will say though is that if we can penetrate both active duty and veteran populations, I do think that between DOD and the VA, there is opportunity for us to actually make way bigger system change quicker than we can outside of DOD and the veteran population, just because many people do seek services within those departments. That if we can get OCD well known, well understood for assessment, well understood for effective treatment, I do think that we can make way bigger systems change that I'm more hopeful about than trying to do it in the private sector. So I think there is a lot of benefits to it, but yeah, the whole system has to change and be on board and make changes that are going to make assessing and treating much more easy and accessible.
Yeah, great points. And for any international fam joining us, DoD would be the Department of Defense. Also, for anybody that's newer to learning about OCD, the Y box would be our Yale Brown obsessive compulsive scale that helps us really be able to gauge the severity and frequency and give us all the really helpful data to know where we're starting, what's our baseline, what does improvement look like, etc. And so yeah, I think that's a really great point too, because being able to harness that attention and that education towards Department of Defense in that example of what you were saying, Liz, is a great place to start. And sometimes when there's a lot of things that need to change for any really good movement to happen, it can feel demoralizing for folks because they can go, well, so much has to change. This is never going to change. And we spoke even at the very beginning of the podcast to that really the important piece of hope. We really need to be able to have this emphasis on hope. And so I love what you said there because you're saying, I think even more though than in the general population, there's a better chance of getting some of these systems of change because of just where all of this information then ends up collating within the Department of Defense. There's still hope to be had. And so I think that's a really beautiful point as well.
100%. Couldn't agree more.
So let me ask you this in terms of working with the vet population, if somebody has disclosed or maybe has a history of disclosing, whether through behavioral health or sick calls over the course of their military career, different events of anxiety, distress, depression and sadness, trauma, does that make it easier for them in some way once they're a vet status to have that record of we can see how this has developed over time? What do you think?
I think that once you are at the VA and you're entering the VA and looking for services and they get you with a clinical psychologist or a clinician, they're going to do a full assessment to understand what's going on. So whether that's been previously disclosed and is in your record or chart, or whether it's something you're sharing for the first time, I would hope treatment's going to be the same. And because either way, we should be starting with a full clinical assessment when you're coming in for services. So if it's well documented, maybe in advance, people would have a better idea of what services you might need coming in. But either way, a full assessment should really determine that. And so again, with every new patient that anyone sees as a clinician, we should be doing a full assessment, clinical assessment to understand everything that's going on with that patient, because we wouldn't want someone to have, for example, well documented anxiety or OCD, but actually their primary thing they're dealing with right now is substance use or PTSD. And we ignore that because we only look at what's documented. So I don't know the answer to that, but I don't think it would necessarily change when you get to searching for services.
Well, I think that's helpful, though, at least from the functional side of having worked in the VA and your experience of that. Because I will, and again, I'm going to share over on this episode's blog just different videos and accounts. And in researching for today's chat, I was even hearing that. And that just may be a piece of the myth busting that we get to do here because some of the veteran and when they were active duty folks that are sharing their personal stories out there on social media do have that sense of if I don't have a paper trail, then I'm going to be screwed when it comes time to needing treatment. And you're saying, no, actually, this is what we're not just going based on records, but we have someone coming in and doing their full clinical assessment as well, because there may be things reported, there may be things changed, there may be things that were never reported. But that doesn't mean that you're going to get to the veteran side of things and be out of luck and not be able to get help that you need because you didn't tell your commanding officer while you were active duty. And so I think even in of itself, without knowing the for sure answer, I think that does some myth busting. And I love that in terms of the broader education around this topic. So as we're approaching our close today, part of the importance and the timeliness of this episode is we have Memorial Day coming up. And I think a lot of times we think about people that we've lost, of course, that have paid that ultimate sacrifice in terms of combat or well in duty. But also, I really have a heart for and want to address, because there's certainly a stigma around this as well, for people unaliving themselves and suicide that have lost still the ultimate sacrifice and have felt maybe alone, maybe felt like that was the only option. There can be so many different pieces that go into that. But I want to honor as we go into Memorial Day here, really thinking about those we've lost and the suicide rates amongst both active duty as well as veteran population is staggering. And again, I'm going to have links to the most up-to-date research. They tend to do yearly different statistics, but they also have studies that look over different time spans. And so just wanted to take an opportunity to talk about, again, part of the reason why it's so important to talk about mental health, recognize that, take the shame away, decrease the stigma, whether we're talking OCD or anything else, is because you matter. Your life is important. And we do see staggering statistics here for our service members and our veteran population that have died to suicide. And so just wanted to bring up that subject and also see if you have any thoughts that you would offer on that from your experience in the VA, or just we know suicide rates in the mental health population, even in the general population, are just staggering as well.
Oh, yeah. So tough conversation for us to have, but so important to be having it. I think that this, again, goes back to that important message that there is treatment and there is hope for everybody living with a mental health condition. And I think so many times veterans are suffering in silence and they're not talking about what they're going through because they don't think people can help them. They don't think anyone can understand. They don't think that pain can go away. And the reality is that we may not be able to fully understand. None of us can understand any other person's battle or struggle fully. but we absolutely can treat. And I have seen and I know that countless veterans, countless active duty, countless individuals with the right treatment can get not just relief, but be able to fully function and not have these symptoms, whatever symptoms you're dealing with, be it PTSD, depression, anxiety, substance use, OCD, trauma, you name it. They don't have to be in the front of your mind. They don't have to be something that makes decisions in your life. And instead, you can have yourself back no matter what you've been through or no matter what you're dealing with. And that's the message I want to send. I want to send that message that there is never, I hear a lot, well, I've gone too long, or I'm too far gone, or it's too late for me for treatment. That doesn't exist. There is not a time when it is too late to be treated. I've treated 80-year-olds, we've treated 4-year-olds, right? You can treat anybody who's dealing with a mental health condition. And the reality is, though, what's more important is that people really understand what evidence-based treatment is and what it means. And what that is that for every diagnosis, there is an evidence-based effective intervention that works. And it is 100% critical that that is the focus, that we are focusing on when we get a diagnosis, getting the right appropriate treatment versus just any treatment. Because what happens, and I'm so big on this, is that when people don't get the right treatment, it further reinforces that narrative that I can't get better. Treatment doesn't work for me. This is hopeless. And the reality is that we should be completely shifting that narrative as a society, because there is treatment for any mental health condition that you're dealing with, and you do not have to suffer in silence.
Very well said. And even if it doesn't get to the degree of suicide, again, full circle in thinking how we started off this season talking about that overlap with substance use disorder and OCD and PTSD and all of these different aspects for our vets. Again, it's that there's hope beyond this. And a lot of people get into something like substance use disorder because they are trying to cope and survive and all of these different things. And so to be able to have evidence-based treatment where we can go, hey, this isn't just a shot in the dark and this isn't just a drink or a hit on something. This is, we know because we've seen it and we can document it and we can study why this wasn't just a fluke, that this can change for you. And so there is hope available. I would imagine, and to the degree that you feel comfortable sharing, Liz, I would imagine even you said you had 2 inpatient hospitalizations. So I would imagine it's already even hard enough to be in such a severe place and trying to survive going into that first hospitalization. I imagine even going into the second hospitalization. Sometimes it can feel like hope is crushed. The fact that I even need to be back here, is this ever going to change for me? And so you can be in that space where it can feel beyond hopeless, and yet we can look and see how life-changing, how different the right interventions, the right support, the right education can be on your quality of life. It's profound.
100%. And for me, there was a lot of stigma. I will say my first hospitalization inpatient was involuntary. And so it certainly was one that I wasn't willing to go on my own. My parents made that choice for me. I was a minor. And the real reason I wasn't willing to go is I had tried years of treatment and I wasn't getting better and nothing was working. What I didn't know is that I'd never been in front of the right treatment. So it was the wrong treatment the whole time. So of course it didn't work, but I didn't know that. And so I didn't think I could get better. I didn't think there was hope for me. And I certainly wouldn't have willingly gone to get treatment. And so the second time, while I was upset that I needed to go back and that I didn't manage my symptoms on my own and didn't continue doing the work I needed to do, or never maybe originally did all the full work I needed to do, I was much more willing at that point. I think that I at least knew treatment could work. I at least knew that I could get better if I worked hard. And so, yeah, I think that it's really hard for individuals. If we're telling you we want you to get the right evidence-based treatment and to get better, what that also means is that you haven't had that yet. So of course you're skeptical. You're not sure if that's true. You think it's different for you. And there are so many countless stories where it is living proof that if you get the right treatment, you can manage your symptoms and have that life that you deserve.
Well, and I can say from my own lived experience, you can think some of these are so core, you don't even necessarily think of them as mental health as much as part of your just personality and your affect and all of this. And you go, well, I don't know that this could ever change. And then it can, and it's indescribable having that experience and that kind of freedom. And it's hard to conceptualize sometimes that something so core to the way you think and the way you function could shift. And we're not talking like it has to be a 180-degree shift. We're talking about a different understanding, a different reasoning, a different learned response in the brain. All of these things can make such a dramatic difference. So there is hope available. And I love just that emphasis on hope. And, fam, for some of you out there, you may be like, it's exhausting and I'm trying to stay above water too, but I am the hope bearer for my loved one. And I want to say thank you for the love and for everything you do to hold that hope. If you're also feeling crushed by hope, whether it's from your own lived experience or just feeling like my loved one is continuing to struggle, and I can say, even as a mom, and Liz is a mom as well, like seeing your child suffer, seeing your loved one suffer, and feeling like you have nothing you can do to change that for them can feel heartbreaking. But you holding that hope does make a difference. And if you're feeling depleted, then surround yourself with your village and reach out to your fam, to your besties, to your people going, okay, so I'm the hope holder and I'm having a hard time even holding my own hope right now because we're better together. And as a community, with the right education, with the right support, we can keep that hope afloat. And there's always, always, always going to be people out there cheering you on, whether you've met them yet or not. They're here for you and we're better together. And so, any final thoughts that you would want to say to the fam in terms of just facilitating some of that hope and letting it float out to our fam?
Yeah, I couldn't agree more. I always talk about how you have to have a champion and you have to have someone who advocates for you when you can't advocate for yourself. So, to the family members or to the non family members that are acting as family members or that are someone's support system, you guys are the ones that make the big difference in pushing us to get into treatment and helping find us the right treatment. Oftentimes, when we're in the throes of our illness, we don't have capacity to search and to find and to do the work and to hold the hope. And so you have to hold that for us, right? And you have to continue to not just be our champion and helping get us the right care, but also in reinforcing and reminding us that hope is available, that help is accessible, and that we're going to get there because oftentimes we've lost that ourselves and we need other people to hold that. And so family members are the glue. And again, sometimes family member isn't a biological family member, right? You're
Right.
you're a stand-up family member in different ways. And you change lives. And I know that for me, without my support system, I certainly wouldn't be sitting here today.
Yeah. Yeah. Loved ones and chosen family. That's who we are. And we're better together. And not only when it comes to OCD, but also just wanting to recognize, thank, and appreciate the sacrifice that family members and that glue for our military members, our active service people, and our veterans, the way that you support, whether it's your soldiers, your sailors, any person that is paying that ultimate sacrifice, you are also sacrificing and being that glue. And so I want to recognize you today too for our military fam and our veteran fam and just thank you for that ultimate sacrifice. I really struggle to even come up with concise, cogent words there because it is such a unbelievable gift. And we just want you to know that you are appreciated. And with that, Liz, I loved this conversation. I'm so appreciative for you taking the time and carving it out of your very, very busy schedule. And I look forward to continuing to hear and learn and grow and hold hope with you and our amazing community as we continue to do life.
It's truly my pleasure. And thank you for everything that you do, Nicole. It's amazing and important. And I think that the message I always want to send is no matter who you are, where you're at, health and hope are always available. Don't lose sight of that.
Thank you for that. All right, fam. Wow. This is such an important topic, and I really am so glad and grateful that you could join our discussion too. Another big special thanks to Dr. Elizabeth McIngvale for imparting her wisdom and knowledge with the fam. We're very grateful for what she has brought to this discussion, and that brings us to the intrusive thought segment, which for new family joining us is my application segment of the show. It's that time where we really aim to put into practice the content that we cover in each episode, and today is no different. And since today is all about combating stigma, and it's all about honoring and remembering those we've lost, I'm going to take a moment to practice what I preach and really remember and focus on the service folks that we have lost to suicide. I know this is a triggering topic, but it's one that I haven't heard really singled out or spoken about exclusively when we celebrate this holiday. And either I'm just in the wrong circles, or this speaks to a wider spread problem in how we address or talk about suicide. There is a myth out there that if we speak it into existence, it could plant the idea or encourage more people to attempt it. It doesn't work that way. But what research actually shows us is talking about it open and honestly actually is one of the greatest forms of suicide prevention. And when we look at statistics, fam, the reality is staggering when we look at our military and veteran population that we have lost. A 2021 study from Brown University, yes, the same Brown that helped to collaborate on the Yale Brown Obsessive Compulsive Scale that we mentioned earlier in the show, estimated that nearly 6,400 veterans died by suicide in 2021, which averages out to more than 17 vets per day. The same report found that over the past 20 years, since 9/11, more than 30,000 vets had died by suicide. But what's even more disheartening is that out of all the conflict following 9/11 until the date of that study in 2021, the number was 4 times higher than people who actually died in those conflicts themselves. To break it down more succinctly, from 9/11 2001 to 2021, 7,057 military personnel were killed in the line of duty or during military operations. Now, compare that to the 30,000 vets who died by suicide in that same time span. It's absolutely devastating. Furthermore, a 2022 report from the Department of Veterans Affairs found that, again in 2021, the suicide rate for veterans was 71.8% higher than for non veterans when compared to the general population, adjusted for sex and age differences. And that means for military families, parents, and children who already missed birthdays and Cub Scout badges, weddings, or births, now they miss it all. And there really aren't words to describe that sort of grief and pain. So this Memorial Day, we are remembering the heroes we lost, both in military operations and to suicide. We honor that their mental health mattered, that their families matter, and that it's important that we don't forget or miss the value and importance of mental health support. Because yes, we have a long way to go, but also yes, we have hope. So I want to point to a few resources because this is the leading cause of death now for our vets. But these resources can and do make a huge difference. So first off, there's 988, which here in the US is the Suicide and Crisis Hotline. Additionally, starting in January of 2023 here in the States, the Department of Veterans Affairs started a new policy for eligible veterans in acute suicidal crisis to go to any VA or non-VA facility, which is huge, VA or non-VA facility for emergency care at no cost as a veteran, which again, huge, no cost. And this can cover emergency room care, inpatient or residential care up to 30 days, as well as outpatient services for up to 90 days. Again, no cost. And what's really powerful is that now in 2024, we're able to look back at 2023 when this program started. The first year is complete. And since its inception, nearly 50,000 veterans have received free emergency suicide prevention care in 2023. There is no doubt that this program has already saved a number of lives, and it's an important resource worth highlighting. Also worth mentioning, the USO, otherwise known as the United Service Organization, is also dedicated to providing education and resources to try and address the suicide rates among active duty personnel, which prompted them to create some programming through the Center of Disease Control, also known as the CDC, to address what in some branches of the armed forces are the highest suicide rates since World War II. And while I'll have all this info on the blog as well, I'll go ahead and verbally mention that if you or someone you know is struggling with suicidal feelings, there is the Military and Veteran Crisis Line, as well as dialing 988, where you can press 1, chat live, or text 838255. In closing, I'd like to take a moment while we remember and listen to this tribute for the lights extinguished, for those lost, a tradition that dates back to 1862 with the song Taps. And while this song is public domain here in the States, I'm going to link the YouTube video where I grabbed this performance from because I noted a really powerful comment that was just authored a few days ago by @Curious1673. And he said, quote, "A soldier doesn't fight because he hates what's in front of him, but because he loves what's behind him." End quote. Family, may we remember those service people and the loved ones, and the chosen family behind them. May we never forget the ultimate sacrifice all of these people have made. And may we remember our ability to create hope and change, safety, and futures by combating stigma, embracing mental health, and remembering that we're better together. We remember and we thank you for your service. Thank you for joining me and our OCD family community. If you enjoyed what you heard today, please like and subscribe to the OCD Family Podcast wherever you enjoy your podcasts. Did you find this content helpful? Please consider leaving a review. The more people that know they're not alone, the better. For more information regarding today's podcast, please visit ocdfamilypodcast.com and remember to join the email list while you're there. It will provide you with the most up-to-date information, resources, and the down low on the family chatter. Oh yeah, nothing says family like Elizabeth and me honoring our service, family. That's right, I went there. And you can too at ocdfamilypodcast.com.